This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, everybody, and welcome back. Welcome back to the SimKit podcast. I am here with a familiar voice, a friend of the show, an associate, I'd say, of mine in Dylan War. War has made some life changes. I want to hear about that before we dive into our topic today. And we're going to be discussing a case that you lived, breathed, healed, a patient that you worked with who had an interesting differential, a case of altered mental status in its own right. And we're going to talk about the complexity of that case. So, Dylan, welcome back. Thank you for joining me today. And yeah, tell us a little bit about your life journey, where you're at, and the case that we're going to be talking about.
Jason, I am always happy to come talk to you about medicine. And in the last couple months, my life has changed pretty significantly. I've gone from Philadelphian to a Phoenician here. My summers have gone from sticky jungle humidity to just the dry heat, as they say here in Phoenix. This has been my first couple months of attending hood. I am getting a sense of what it means to be, as I call, the adult in the room, which I think in some cases is particularly challenging, but I'm viewing it as a growing experience. And I think following some of my passions here, whether it's talking to you or getting involved in the residency that I am now a part of there, I think is going to give me a lot of things to chew on as I move forward into the next couple months of my career and hopefully the rest of it. So we'll see where I go. But I have a case for you. I think it gives us a good sense of how to talk about some differentials for altered mental status. And then we can talk about the specific diagnosis in this case and dive into some of the pathophysiology and treatment. Sound good?
That sounds perfect. Let's do it.
All right. So just to set the scene a bit, and even though I'm attending now, this is a case that I had at the tail end of my residency training. It was at one of my institution's community sites. It's one of those places that has some services in-house, but doesn't have all the bells and whistles of a tertiary care center.
Sure. Yep. I'm a community doc at heart. I work anywhere from that ivory tower all the way through to basically freestanding ER. And it sounds like you have a hybrid environment there. You have some services, which is great. You want to have the backup. You want to have resources you can pull in. But man, I actually really love working in that sort of solo shop.
This institution actually feels very well equipped compared to the community site that I am working now. But let's talk about this case. This patient is in her early 30s. She presented to our ED for acute onset left-sided headache, vision loss, expressive aphasia, and altered mentation. On the day of presentation, she developed an acute severe headache over her left eye. Her symptoms rapidly progressed to vision loss, eye twitching, and then expressive aphasia, which understandably prompted a call to EMS by her mother, who was pretty concerned, as I would be too as a parent.
Yeah, pretty concerned would be an understatement there. As a parent myself, my God, you have a patient here. We'll get into that differential in a second, but even the layman would start worrying about maybe bleeding or a stroke. So yeah, I'm sure mom was quite concerned. What did the patient look like?
Her initial vital signs were blood pressure of 145 over 103, heart rate of 108, respiratory rate of 17, and she was satting 99% on room air. Her AccuCheck, as a good fifth vital sign here, was 75. Initially, her ABCs were intact. Her initial neurologic exam was notable for aphasia, right-sided neglect, and a right hemiparesis. She followed no commands, had no movement in her right arm, and only weak withdrawal in her right leg. And besides that, the other physical exam system elements were pretty unremarkable. And with that, we drew some stat labs and off to the races.
Holy cow. Okay, this is real deal, right? I mean, sometimes you get those EMS reports, you hear about a true neurologic emergency, and then they get there and you find that that was not the case, that it was some other non-epileptic seizure or something along those lines. Certainly panic attack, those cases come across our departments all the time. But this is real. This is a real deal. You very briefly mentioned a severe headache over her left eye, and then we know her neuro exam, we got her vital signs. I guess one of my very first questions and just thinking about this case is she pregnant or has she recently been pregnant, right? This is a woman in her 30s. So these types of manifestations should not be commonplace, and we can't forget about that patient demographic. Sort of thinking about the preeclamptic or hypertensive emergencies of pregnancy and postpartum, those ones scare the bejesus out of me because we all know we want to get that baby out as part of the treatment algorithm. And if the baby's already out, man, that's harder. But then just thinking more globally, severe headaches. So we're going to think about subarachnoid hemorrhage, intraparenchymal bleed. Again, coming back to that pregnant or recently pregnant patient, we got to think about vascular catastrophes like dissection or cerebral venous sinus thrombosis. The list is pretty big here and pretty serious in terms of the potential causes.
I think this is a scary presentation, and you think immediately about the brain, right? And I think what we're left with is we have to rule out something intracranial first and foremost. In addition to pregnancy, when you are presented with a case like this, you're limited. You can either attempt to get a urine pregnancy immediately, which is going to be hard with someone with this sort of presentation, or you have to rely on your serum HCG, which is still going to take some time. But what I can say is from physical exam, no obvious gravid abdomen that you could really drill down on and make you think that this person was pregnant or had recently given birth. But with that in mind, we have to think about stroke. And stroke is going to be super high in the differential here, whether it's a hemorrhagic or ischemic stroke. And as you can imagine, in this center, we called a stroke alert and she was taken emergently to radiology. While the patient was whisked away, we tried to review the EMR for any additional background we could find on this patient.
I think that's a great approach, and kudos getting that early AccuCheck, because fixable things, we want to find them early, right? And that sometimes gets put by the wayside, especially if you start going down this pathway of stroke. Granted, it's harped upon checking the sugar early, checking it and making sure that you're not getting a mimicker, but it gets forgotten as you talk about getting CT ready, getting IV access, doing your BFAST, doing your NIH, getting your EKG, reviewing any contraindications to TNK or TPA. All those things can get in the way of doing that. I'm glad you hopped into the EMR, but certainly in this patient, you had a right approach, right? We're wondering, are you or have you been pregnant? And we start thinking about those like preeclamptic or eclampsia related illnesses around 20 weeks or so. And so you would imagine you probably could see it at least on ultrasound, depending on the patient's habitus, maybe by feel, but you can find that part out relatively easily. And the other really valuable thing you have is the mom in the room. So unless they're estranged and she just didn't tell mom about this recent pregnancy that she had or delivery that she had, that bit of information is going to be super helpful as well.
Absolutely. And from what we could tell, there was no hint of pregnancy. And unfortunately, in this case specifically, mom didn't show up until a little bit later. This was all secondary EMS report until after the patient came back from CAT scan.
Okay. Plot thickens.
The plot thickens for sure. So we reviewed the EMR. We did the best to find out if we knew anything about this patient that could maybe inform our care. Because the patient's off the CAT scan right now, we have a couple seconds here to get a sense of who this patient is. And she happened to be admitted through our emergency department 12 days prior for a hemoglobin of 1.8. And that was attributed to menorrhagia from her uterine fibroids. And during this admission, it was complicated by new systolic heart failure, which they attributed to this anemia. During this stay, she received 4 units of packed red blood cells over the first day of this 3-day hospitalization. The hemoglobin improved to 7.8. She seemed to be doing a lot better from a symptomatic standpoint and was subsequently discharged. And that's what we know about her just from the header of the hospital course from her discharge summary, which we luckily had.
So thank God, first and foremost, that you've had a recent point of contact with this patient. We have to talk further about her mental state and her ability to give her history. But if you don't know and they're coming out of the blue, that really broadens the differential and makes things a lot more challenging. But you have this data point 12 days ago. Sorry, she had a hemoglobin of 1.8. Did I hear that right?
Yeah, 1.8.
Holy cow. Yeah. And during the course of that stay, did she have any surgical intervention? Did they remove the fibroids or was there anything further that you noted in the EMR?
No, not that we saw. She arrived there. She had a low hemoglobin. They were like, wow, this is your fibroids. And she just got tanked up with blood over a couple days stay. And then when she looked a little bit better, she was sent home with planned for outpatient OBGYN follow-up.
Okay, impressive. And you brought her from a 1.8 to a 7.8, or the inpatient team did so. So significant change in her hemoglobin there, and 4 units were administered. That's important to know.
Yes, for sure. And that'll definitely come into play as we talk a little bit more about this case moving forward. Now, this community site, the neurology attending calls the ED team after the stroke alert is called to discuss the neuro exam and review imaging. We got the neurodoc on the horn just as the non-con CT head was finishing. And unfortunately for this patient, in her 30s here, had an acute left occipital intraparenchymal hemorrhage with some surrounding vasogenic edema. And we talked to the neurologist on call, and with his help, we added a CTA and then a CTV. And luckily for her, they showed patent cerebral veins, no large vessel occlusion, and no evidence of EV malformation or other structural cause for this hemorrhage. But yeah, she had an acute left occipital intraparenchymal hemorrhage. Now, unfortunately, when the patient returned from CT, she suffered further neurologic deterioration. She developed this fixed forward gaze. She wasn't responding to really any painful stimuli, and her respiratory rate was slowly decreasing. And at this point, we had to take her airway for airway protection. So she subsequently was intubated, she was sedated, and at that point, there's not much to do except admit her to the neuro ICU for further management. And I think of note here, no antihypertensive medications were required while she was here in the emergency department. Her blood pressure stayed in the 130s to 140s throughout, even though she had this abnormal CT finding. What do you think so far about this case, Jason, and what we've talked about?
So I feel like I have an uneasy sense of, okay, maybe we found culprit, but I don't know if it's fully fleshed out in that space. Like we were saying, what was the neurologist's opinion of the CT read versus the patient's manifestations? The idea of a fixed forward gaze and non-responsiveness in someone that has this vasogenic edema and a new bleed, then you have to think about seizure, right? Was she actually in the throes of a epileptic seizure at the time when she came back from CT? I don't know if you chose propofol as your agent or what you had post-intubation, but I feel like that's probably a reasonable direction to go. And as you think about that and you think about her hemodynamics, you mentioned some mild hypertension, I guess you'd say, at 147. That's not a number that makes us overly concerned as emergency clinicians. I don't know if she lived at that height constantly, and we have some pre-existing data on her. So knowing what her blood pressure is normally, I think would be really important, both in terms of determining if propofol is the appropriate agent and then seeing if this is a major outlier. If she's normally 100 over 55, then that's a marked change for her and something we have to think about as we recognize her clinical deterioration.
In terms of seizure activity and thinking about seizures, I think that began to creep into our minds, and we use propofol for post-intubation sedation. By the time that we had her squared away, her serum quantitative ACG came back, and that was a negative, thankfully.
Okay, excellent.
Yeah, no, really crossed that one off the differential, right? So we get her over to our tertiary care center. She gets a repeat CT head upon arrival to the neuro ICU, and this was stable. And as neurologists do, they slapped a continuous EEG monitor onto her, and it showed that she was in refractory non-convulsive status. And it was originating from both of her occipital lobes, which is, as you hinted at, maybe one of the reasons that she was having some of these symptoms when she first came into the emergency department, especially with her decompensation. And it was refractory to the propofol infusion, and she ended up needing 3 different anti-seizure medications while she was in the neuro ICU to control her seizure. And MRI brain that was obtained 10 hours after her initial presentation showed vasogenic edema in the left greater than right occipital lobes and her left parietal lobe. And thinking of differentials, there was also no associated enhancement to suggest an underlying mass.
Okay, thank God.
So the final clinical diagnosis here was agreed to be PRES with intracerebral hemorrhage complicated by status epilepticus. And it was thought to be related to her recent blood transfusion for her severe anemia.
Wow. All right. So posterior reversible encephalopathy syndrome, not a common diagnosis. And man, that's a complicated picture for me because of the bleed, right? And so the bleed is going to have some associated edema. But when you start thinking about ocular changes, vision associated changes, seizures, headache, and usually I'm thinking about this in the case of a pretty markedly elevated blood pressure. I feel like it's sometimes philosophically talked about because it's not common and it doesn't come up on our list in the altered mental status patient. It's considered academically discussed, but not really often recognized or treated or truly considered outside of the exercise of broad differential diagnoses. This is rare. And it's not something that I would think about in, a 30-something-year-old at this time in her life with those vital signs that you presented me with.
This is absolutely an atypical presentation for press, and that's because I'm shamelessly plugging the case report on transfusion associated press that I was a part of that came out recently in August 2024 in AGEM. I really hope that reviewing this case, we can highlight press and discuss it here on SimKit for your listeners in a holistic way, both for the diagnosis itself and a little bit about blood transfusion associated press, just to have it in the back of our minds as we see patients in the emergency department.
Let's do that momentarily and just think about her case presentation and your management of it. It sounds like you guys did a fantastic job in terms of recognizing true neurologic deficits, getting a code stroke or stroke alert activated, involving the right specialty services, and then very importantly, recognizing a clinical deterioration. I mean, first you diagnose the bleed rapidly, and that's appropriately done, and then controlling her in the ways that you ought to, the ways that these patients need. I give you props in terms of the use of propofol as the post-intubation medication there. Getting her over to the neuro ICU, getting that EEG going really helped in the diagnosis. And of course, MRI. When we have CT, CTA, I've certainly seen sort of the radiology interpretation, increased vascular effect and edema around vasculature, suggestive of the diagnosis of Press syndrome. That's helpful when that's there, but the MRI sounds like it really helped clinch the diagnosis in the end.
Yes, the CT itself noted some possible vasogenic edema, but really it was the MRI that was the nail in the coffin for this diagnosis specifically with her.
Yeah.
Let's talk about press, because I think it's one of these diagnoses that comes up occasionally in academic discussions, particularly when you talk about hypertensive encephalopathy. I think it's one that we should be aware of as emergentologists to be able to handle and diagnose in the ED. So first of all, it has a bunch of different names, and there's a movement towards the name reversible posterior leukoencephalopathy syndrome, or RPLS. This abbreviation, as you can tell, does not roll off the tongue nearly as easily as the one for press. And honestly, no matter the name, we still haven't really figured out how to appropriately describe the condition in a name, as it's not always reversible and it isn't always confined to the posterior regions of the brain. Now, press is increasingly recognized, but its pathophysiology is still not fully understood. We have some proposed mechanisms. It includes distorted cerebral autoregulation, abnormal cerebral vasoconstriction, and maybe some endothelial dysfunction. And likely it's probably a combination of all of these. Now, as we've talked about and hinted about, press is most commonly associated with hypertensive encephalopathy, but also has been described with eclampsia, cytotoxic and immunosuppressant drugs, autoimmune conditions, kidney disease. And then, as we talk about in this case report and in this case here, blood transfusion is another rare cause of press that is honestly underrecognized and has been described in case reports really only in the neurology literature.
Good for you breaking ground in that space. This diagnosis is somewhat confusing to us, I think. One, in part because you mentioned it, naming something that is both reversible and posterior, that's not necessarily reversible and not necessarily posterior, that's got problems in it, right? We need someone from JAMA or Annals to come up with a catchy acronym that works for everybody and is cool and hip and memorable, but we're not there yet. The things that I do think about in this diagnosis, you talked a fair bit about. One, in first learning about it, I do remember this sort of theory related to the diagnosis that our sympathetic innervation to the vessels in the posterior aspect of the brain are thought to be more tenuous, a little more susceptible to really large spikes in blood pressure. So maybe that's why we get more vasogenic edema in the posterior fossa or in the occiput. So we see the diagnosis more often there. That helped me just remember our thought about that cerebral autoregulation or the vasoconstriction that may be dysfunctioning in this patient. And then you mentioned endothelial dysfunction, and that just helps me think about cytotoxic agent, immunosuppressants, people on chemotherapy, people on other weird drugs, for lack of a better term, that may also be associated with this disease and can cause those leaky vessels, again, leading to some of that vasogenic edema.
I think that's a great way to piece together the pathophysiology of this condition and the risk factors or the associated condition. By understanding some of the process there, it may help you make that mental jump when that patient comes into the emergency department with a presentation like this.
Totally.
Now, I think this is important here. PRES is a clinical and a radiographic diagnosis. You can't have it without both of these components. Therefore, it is super important to be familiar with the clinical components of PRES as much as the ultimate radiographic findings. Now, the clinical syndrome of PRES is headache, confusion or decreased level of consciousness, visual changes, and seizures. And all of these components can be quite subtle and require a thorough and detailed history and physical examination. Importantly, and this is important, high blood pressure, although common to many patients with this disease process, is not necessary to make the diagnosis. It is not one of the diagnostic criteria. So this diagnosis has to be in your mind when patients present with this constellation of symptoms, regardless of their blood pressure. Now, the characteristic neuroimaging findings are posterior cerebral white matter vasogenic edema. You can also have intraparenchymal and subarachnoid hemorrhage, and this ties back into our patient case here. So don't let bleeding throw you off. It isn't just vasogenic edema. You can have subsequent effects from that edema, such as hemorrhage. And these findings, as you said, Jason, earlier, are often apparent on CT, but are better visualized on MRI.
Yeah, that really helps tie this picture together in this patient presentation where this really wasn't on my differential a lot. And I generally think about these patients who are markedly hypertensive, who I'm thinking of, a hypertensive emergency, a hypertensive encephalopathy, and recognizing that in the patient symptoms that you listed, marked hypertension is not really on there. Level of consciousness changes, visual changes, seizures, headache being on there. But blood pressure is going to be a component in many patients, but it's not universal. And certainly, as you talk about this case, not necessary to clinch the diagnosis.
Agreed. Now, just to hammer this home and link all this together just for some spaced repetition, this patient had headache, visual changes, and all of these neurosymptoms. And retroactively, we can attribute all this to frequent focal seizures, her initial expressive aphasia, her right-sided neglect, and decreased level of consciousness. And we can make this assumption as she was found to have refractory status when she was ultimately connected to an EEG. And these deficits resolved as her seizures were treated. So as they saw the seizures resolve on the EEG, these deficits that she initially had coming into the emergency department improved. So with that, it's headache, visual changes, and then these abnormal neurosymptoms. That just might be seizure, which is super interesting. And I think really informative in terms of how you can think about this diagnosis. And then I think just to tie it up here, her MRI demonstrated vasogenic edema in her occipital and posterior parietal lobes. And remember, this is a clinical and radiographic diagnosis. So this combination was the final thing that was like, this is PRES. She had the constellation of symptoms and she had the characteristic imaging findings, which are both necessary to state that this person has PRES.
Yeah, fantastic. It does tie her up, or her clinical picture up well. Obviously, a critically ill patient. Glad to hear that as her seizures were treated, a lot of her neurologic deficits improved or resolved. But that's a challenge. Did your CT A or V give you any information to point you to the diagnosis, or was it really just in the MRI?
It was in the CT. There was some commentary on this could be consistent with PRES, as radiologists hedge. I think it was there at the forefront of our minds right before her transfer to the neuro ICU. But I think you can make hedgy bets as a radiologist, and you can also make some hedgy bets as an emergency medicine doctor too. And I think we knew that we had something along those lines, and all we really could do was manage her symptomatically, right? Even if it was PRES, there's not much to do. And as we'll talk about in terms of ED management, besides treat the specific symptoms underlying the press that they're experiencing.
Yeah. No, I think that's a great summary and way to think about these cases where a serious diagnosis is on your differential, but not definitively confirmed. And so if you're talking with your neurocritical care, your intensivist, and you're saying, yes, we have this bleed. Yes, we have these seizures, maybe associated with the bleed by itself, but we're all still thinking about press. And that helps them maybe continue some diagnostic momentum in making sure the diagnosis is either really fully ruled out or ruled in.
Absolutely. I think it's so easy to just stick to a diagnosis and then continue along a pathway without really stopping to reconsider. We've been beating around the bush here, and I think we should just really state this plainly, the ED management of press, and it's fairly simple. It's our job to identify the clinical syndrome, attempt to determine and manage whatever the underlying etiology is, and then to facilitate the diagnosis with the MRI brain and potentially an EEG. Our job is to be the quarterback for this diagnosis.
Mm-hmm.
And then ultimately care is going to include whatever supportive care is required, right? So is it airway management? Is it seizure control? Is it blood pressure management, depending on the case and the patient in front of you? And the prognosis of press is typically favorable if recognized and treated early, with symptom improvement, resolution, and really only a few days to several weeks. But if you're not on top of it, and if you miss the diagnosis, it can progress to coma or irreversible ischemia. Now, given that the majority of patients have associated hypertension, which is why as emergency medicine docs, we think blood pressure and press, one goal is blood pressure management. And there's no specific established antihypertensive regimen that we have for people with press. From the little data that does exist, treatment is recommended if the blood pressure exceeds 160 over 110, with a goal of about 130 to 150 over 80 to 100. So kind of in that same antihypertensive regimen for a brain bleed, right?
Mm-hmm.
We're thinking about closer blood pressure management and control, and not drastically reducing the blood pressure suddenly, because it can lead to cerebral hypoperfusion, right? Because it really depends on where this person's living.
Mm-hmm.
Management of the blood pressure is very similar to how we would manage any other intracranial catastrophe with blood pressure management. Now, that does make your clopidogrel, your nicardipine, your labetalol, all those titratable medications great choices if you were dealing with blood pressure specifically. And then we talked about seizures. You're going to treat the seizures you can, right? And I think in the beginning, maybe everyone was thinking that we were setting this up for eclampsia, but if the patient is pregnant, even if they have radiographic imaging consistent with press, call it eclampsia and treat it with magnesium. So once again, it's one of those things that it's like press, but maybe the press is from the eclampsia, and you need to make sure you're treating it as such and not just defaulting to only benzodiazepines here for control.
Mm-hmm.
And for example, in terms of other etiologies, if it's from an immunosuppressive or immunomodulatory medication, just stop the med. So you can see how press is really about targeted management based off the underlying etiology.
Yeah, right. And some of that is easier to say than to do, right? And if it's someone who has a marked hypertension, that's almost easier in my mind. Okay, yeah, that came from the autoregulatory dysfunction, the endothelial injury, the leak. We fix the blood pressure, maybe some of that edema improves. It's harder in the cases where, one, they go on to have seizure, two, if they're using immunomodulatory therapy or chemotherapeutic, it's easy to say, stop the agent, but you're not out of the woods, right? One, we're not going to give those agents in the department. They're far too sick, and we're generally not administering them. But recognizably, it's going to take time. As you mentioned, days to weeks for recovery. We certainly want to recognize the trigger as best as possible. Sometimes it's muddy, sometimes it's clear, but the patient's presentation and what you're doing in the short term is generally pretty clear. Your patient was different. So anything different when you're dealing with blood transfusion associated press? Tell me a little bit more about this. What's going on here?
The water is muddy, as you would say. The etiology of transfusion-related press is particularly unclear. It has been hypothesized that chronic anemia may result in some sort of compensatory cerebral vasodilation, and then the rapid increase in hemoglobin and viscosity when you increase your hemoglobin can cause overwhelming cerebral vasoconstriction, or maybe could overwhelm cerebral capillary autoregulation, and that leads to vasogenic edema and hemorrhage. But these mechanisms are entirely speculative. But it does tie back to what you said earlier about the posterior cerebellum and the posterior lobes being maybe a little bit more susceptible to disorders of autoregulation, particularly in this context.
That's actually my leading hypothesis in terms of the cause for transfusion associated. I was thinking the rapid increase in hemoglobin viscosity, a lot of theory, but again, practically, it doesn't matter. It doesn't necessarily matter. But tell us, like, clearly people have pontificated on this. What's the data out there? It sounds like you might be one of the earlier publishers in EM world. There's some neurology stuff. What do we have in terms of info on this blood transfusion related press?
As you said, there are few reports in the literature about this condition. However, from what we know, these case studies that are out there predominantly describe middle-aged females with chronic anemia, most commonly caused by menorrhagia, who received large blood transfusion volumes and a rapid correction of their hemoglobin. So from the cases that are out there, the median increase was greater than 5 grams per deciliter, and the onset of press has been reported to be 1 to 18 days from the time of transfusion, with a mean onset of about a week. And in about 75% of these cases, the hemoglobin value before blood transfusion was less than 3.5 grams per deciliter. So to kind of paint a picture here, it's a middle-aged female who has chronic anemia from vaginal bleeding with a really low hemoglobin, who then gets it corrected by a significant amount.
Yeah, really low, right? And so we talk about chronic anemia for menorrhagia, but 1.8, less than 3.5. These are shockingly anemic females. And then the inpatient team, 4 extra hemoglobin up to 8, basically. And you're saying greater than 5 is going to be at risk after having this profound anemia.
She got 4 units and went all the way up past 7. So definitely had a pretty significant increase in her hemoglobin in a pretty short amount of time in that hospital stay. And I think that definitely set her up for this condition here. And I think one thing to note on in all of these case reports, only about 38% of these cases had hypertension. That kind of speaks to the difference in a presentation such as this compared to what we see most commonly in the emergency department. And treatment is really no different here. You diagnose it and you provide supportive care, and you treat hypertension if it exists, and you manage the seizures as you're able. That's really all there is to it.
This is a tough situation, and one, again, where I'm still just reeling on the idea of I've already in my mind associated press, hypertensive encephalopathy, nicardipine is my agent of choice. That's where I default to. And supportive care in these profoundly sick and difficult diagnoses is challenging. So, can you bloodlet her? Is there any other treatment, or is the treatment really, truly prevention and support?
You didn't know I have a bunch of leeches in my back pocket. I actually carry them
Perfect.
around and I give them to patients as I walk around the emergency department. But basically, it's really prevention and I think patient knowledge and talking to them about the complications of blood transfusion. When you think about it, we don't really talk about the neurologic complications in the setting of blood transfusion. We talk about allergic reactions and taco and trolley and all these fancy things, but we don't really tell patients that they could have a neurologic complication from their blood transfusion. And yes, it's specific, at least at this point, to chronic anemia, but I think it does highlight that the risks of blood transfusion do extend beyond just the cardiovascular or immune system, but it can really affect your brain. So when we think about prevention, it maybe in this specific setting, when someone has a really low hemoglobin for a really long time, it may be prudent to limit the initial correction of hemoglobin to less than 5 grams per deciliter or reduce the rate of transfusion. But we don't really have any optimal targets, and it would be very evidence-less in this realm at this point. We just need to keep press on the differential for those presenting with neurologic symptoms after correction of severe chronic anemia, even in the absence of severe hypertension. And that's a thing to really hit home here, is that press is all about making the diagnosis. So the best treatment approach for this specific etiology of press, as I've said, is unknown. For now, it's all patient-specific care. And this is something we've hit on multiple times in this case review.
This is a fascinating case, and it's a fascinating disease, but what an amazing manifestation of an illness. Unfortunately, obviously, challenging for the patient. But I do want to know, as we think about it and ooh and ah about the case presentation. What ended up happening with your patient?
On hospital day 2, the patient was successfully extubated after propofol was tapered off without any recurrent seizures. And in hospital discharge, she was awake, alert, and oriented. She had normal language function, she had intact visual fields, and full strength throughout. And there was no neglect. And from my last review of the EMR, she's doing well. So came in very sick and basically walked out of the hospital.
Yeah, that's fantastic. And in particular, occipital lobe hemorrhage. I'm happy to hear that in the end, neurologically, she's doing well and that her vision was maintained. So kudos to you. Great work.
It's a team effort. I think the neurology team here was incredibly helpful, and we did good by her, and hopefully she'll have no recurrences of breast as long as she stays away from 5 units of blood moving forward for whatever chronic anemia that she may or may not have in the future. But that's all I got for you. Jason, wanna hit your listeners with a recap to close us out?
Thank you for bringing this amazing, interesting, challenging, fascinating case to me and to our listeners. Let's just summarize press a little bit. Again, it's a disease with many names, none of which seem to really have hit the nail on the head. But thinking about it globally, first, let's talk about patient manifestations. We talked about headache, confusion, or altered sensorium, decreased level of consciousness, whatever name you want to put to that, visual changes, and seizures. And in that space, the patients that are at risk, we're talking often about people who have marked hypertension, and recognizably, there are certain other instances where this disease process can manifest. You mentioned a fascinating one that I wasn't as familiar with in terms of the really profoundly anemic patient and the rapid correction of their hemoglobin. Autoregulatory dysfunction may be more prominent in the posterior part of our brain, so that we do preferentially see that vasogenic edema in the occiput and parietal lobes. That can happen again with autoregulation being overthrown, if, for lack of a better term, from blood pressure or from other causes like the viscosity or changes from hemoglobin correction or from medication. So thinking about patients that have chemotherapeutic immunomodulatory meds, these are other patients at risk. A very important take-home point here is that hypertension is not necessary to make the diagnosis. And Dylan, you mentioned to us all that it's that clinical manifestation, again, headache, decreased LC, vision changes, seizure, plus radiographic evidence of that vasogenic edema, preferentially in the spots that we talked about, but recognizably it can be other parts of the brain. Management's hard here, particularly in the setting of not having a lot to do. In someone who's markedly hypertensive, I love nicardipine. I think that it's something for me to focus on to try to control blood pressure. As you mentioned, airway procurement, if they're seizing in status, have decreased level of consciousness where their airway simply needs to be maintained or protected, and then initiating the right seizure treatment. If you are intubating, propofol is a great agent because of its anti-epileptic properties, probably some true anti-epileptics if you're diagnosing seizure in the emergency department. And then really importantly, as you mentioned, we're not living in a vacuum here. It's important for us to be the ones that put this diagnosis on the radar for the team and the team that's taking over the care of the patient. But don't be a cowboy here. Work with your neurointensivist. Talk with them about your considerations, concerns. Set them up for that EEG and that MRI, and you'll do well by your patient like you guys did here with this young woman.
Jason, that was an incredible summary. Thank you again for having me. It's always a pleasure.
Yeah, thank you for bringing this interesting case, this really interesting diagnosis to me and the listeners, and learned a lot. Looking forward to having you on again sometime soon.